Greetings, I'm Dr. Carl Nath and I serve as Editor-in-Chief of Mayo Clinic Proceedings. The following presentation is based on an executive summary entitled Primary and Secondary Diagnosis in Medicine, Insights from Mayo Clinic Consensus Report on Membranous Nephropathy, which will appear later online this week in Mayo Clinic Proceedings. This executive summary will accompany the paper entitled Mayo Clinic Consensus Report on Membranous Nephropathy, a proposal for a novel classification by Sethi et al., which will be published jointly and simultaneously in Mayo Clinic Proceedings and Kidney International. This consensus report is based on a Mayo Clinic-supported meeting of experts in membranous nephropathy held on October 29, 2022 at Mayo Clinic, Rochester, Minnesota. An executive summary of this consensus report was prepared because certain concepts that were enunciated at this meeting and discussed in this consensus report are relevant to the particular use of the terms primary and secondary in specifying diagnoses in the practice of medicine. Broadly considered, diagnoses designated as either primary or secondary in medicine are used in at least 4 different contexts. First, the designation may be used in the clinical impression report plan to differentiate the most salient diagnosis from those that are less so. Second, primary may be applied to diseases arising from a genetic abnormality, for example, polycythemia, immune deficiency diseases. Third, primary may specify the original site of a particular malignancy, with secondary indicating metastasis to other organs. Fourth, primary is used to describe a disease process of unknown pathogenesis or cause, for example, hypertension, autoimmune hemolytic anemia, membranous nephropathy, while secondary signifies such a disease process triggered by recognized antecedent or accompanying diseases or other causes. For primary diseases as used in this 4th context, sometimes interchangeably with idiopathic, the unmasking of previously unknown pathogenetic underpinnings ushers in new paradigms and often advances the management of patients with these diseases, and not uncommonly with improved outcomes. Such is the case for membranous nephropathy, a relatively common cause for proteinuria and nephrotic syndrome in adults. In membranous nephropathy, immune complexes accumulate along the region of the glomerular basement membrane that abuts the foot processes of podocytes, with thickening of the glomerular basement membrane and without significant inflammatory cell infiltration in the glomerulus. 70% of cases of membranous nephropathy are considered primary in origin, with the remaining 30% as secondary to some recognized disease or cause. In recent years, landmark discoveries regarding the pathogenesis of membranous nephropathy have fundamentally advanced our understanding of this disease and have altered how this disease is diagnosed and managed. To understand the current significance of current concepts in membranous nephropathy, one needs to go back to studies in a preclinical model which faithfully recapitulates the salient features of human membranous nephropathy. Studies in this model demonstrated that the immune deposits in this model resulted from the interaction of circulating immunoglobulin G with a mysterious glomerular antigen, rather than what was believed at the time, namely that such immune complex glomerulonephritis resulted from the ensnaring and insudation of blood-borne immune complexes within glomeruli. This concept regarding the pathogenesis of experimental membranous nephropathy was shown to be relevant to human membranous nephropathy. Specifically, in primary membranous nephropathy, the circulation houses antibodies that recognize podocyte antigens and thereby instigate autoimmune reactions underlying membranous nephropathy. In 2009, the landmark discovery was made by Beck et al. That in primary human membranous nephropathy, circulating autoantibodies recognize the phospholipase A2 receptor, PLA2R, an antigen present on the glomerular podocyte. This conclusion was at the culmination of studies examining the interaction of sera from patients with membranous nephropathy and proteins derived from normal human glomeruli, followed by antigen identification. In primary membranous nephropathy, the disposition of PLA2R was altered such that PLA2R co-localized with subepithelial immune deposits. In secondary membranous nephropathy, neither were autoantibodies to PLA2R detected in the systemic circulation, nor the disposition of PLA2R on the podocyte so altered. These autoantibodies to PLA2R were present in the majority of cases of primary membranous nephropathy, and indeed the levels of these autoantibodies in sera correlated with the activity of membranous nephropathy. In 2004, a second antigen on the podocyte was discovered in causing primary membranous nephropathy, namely thrombospondin type 1 domain containing 7A. A third antigen involved in primary nephropathy was discovered in 2019, neural epidermal growth factor-like 1 protein. The discovery of neural epidermal growth factor-like 1 protein was facilitated by the use of the sophisticated technique of laser capture microdissection to isolate glomeruli in membranous nephropathy. Since 2019, numerous novel antigens have been identified as contributing to human membranous nephropathy. The discovery of these novel antigens in membranous nephropathy have upended the conventional classification of membranous nephropathy into primary and secondary causes for several reasons. First, the pathogenetic basis for the majority of cases of primary membranous nephropathy is now known, and thus the use of primary in the sense of being idiopathic is no longer justified. Second, for two novel antigens considered to cause primary membranous nephropathy, namely thrombospondin type 1 domain containing 7A and neural epidermal growth factor-like 1 protein, associations are found with malignancies, the latter representing a recognized cause for secondary membranous nephropathy. Third, novel antigens are being discovered not just for primary but also for secondary membranous nephropathy. The nature of membranous nephropathy is thus proximally dependent on the identity of the specific underlying antigen, not on whether the membranous nephropathy is assigned to a primary or secondary classification. Fourth, the primary-secondary categorization is essentially a binary, mutually exclusive one, yet some of the newer novel antigens cannot be uniformly assigned to either primary or secondary categories. Finally, the heterogeneity of disease processes in membranous nephropathy is such that, as commented by Sethi in 2021, each new protein antigen-associated membranous nephropathy is a specific disease that results in the common membranous nephropathy pattern of injury. As a clinical corollary to this concept, and as pointed out by Bobat et al. Also in 2021, there is the need for a refined terminology that combines the target antigen and associated disease to better classify membranous nephropathy and guide clinical decision-making. The primary-secondary classification of membranous nephropathy served the discipline of nephrology for many years, but in truth it was essentially an expedient temporary, makeshift classification that awaited discoveries that would dispel areas of ignorance held together by the umbrella and speciously comforting terms primary and secondary. As made abundantly clear by Sethi et al., recent seminal discoveries have rendered this classification as anachronistic, and in its place the Mayo Clinic Consensus Report on Membranous Nephropathy proposes a novel two-step classification, the first involving identification of the target antigen, the second seeking to define associated conditions and causes. This new classification incorporates recent discoveries, is clinically based, appealing, and pragmatic, and importantly assimilates new knowledge as it emerges. This novel classification provides the needed foundation and points the way ahead for further discoveries in membranous nephropathy. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.